This lecture is presented for the College of Medicine, Alexandria University. It is about arrhythmia for medical students. The conductive system of the heart consists of the SA node, AV node, bundle branches, Purkinje fibers. It transmits electricity from the origin in the SA node to the myocardium in the same time to the left ventricle and the right ventricle. The AV node, sometimes in some persons, the fibers transmit electricity in a fast pathway and other fibers in slow pathway. This dual physiology may cause problems in the future. Again, the conductive system, the SA node, 3 fibers transmit the electricity to the AV node, and then the right and left bundle branches and Purkinje fibers. This is a normal ECG configuration, consists of 12 leads, lead 1, lead 2, lead 3, and so on. The electric wave of the heart, there is P wave, QRS, T wave. From the beginning of the P to the Q, beginning of QRS is called the PR interval. Beginning of QRS to the end of T is called PR interval. And this is the ST segment. Classification of arrhythmia, if it is more than 100, is called tachyarrhythmia, divided into rapid regular and rapid irregular, and below 60 is called bradyarrhythmia, also either regular or irregular. We start by sinus tachycardia. The etiology of sinus tachycardia can be physiologic, pharmacologic, pathologic. Physiologic as in infancy and childhood, exercise, excitement, emotions. Pharmacologic by sympathomimetic drugs, parasympatholytic drugs as atropine, nicotine, caffeine, and alcohol can cause tachycardia. The pathologic causes of tachycardia: fever, hypotension, heart failure, pulmonary embolism, hyperkinetic circulation, anemia, hyperthyroidism. Example of heart rate about 120 in a patient receiving sympathomimetic drugs for bronchial asthma. The management of sinus tachycardia is according to the etiology, is management of the etiology. Now we come to sinus bradycardia, also physiologic, pharmacologic, pathologic. Physiologic as in athletes, old age, during sleep. Pharmacologic by digitalis, beta blockers, verapamil. Pathologic bradycardia in convalescence from infections, hypothyroidism, obstructive jaundice, rise of intracranial tension, hypothermia, and inferior myocardial infarction. There may be in some persons extrasystole or called premature beat. It can be either atrial or ventricular. This is example of ventricular premature beat. The patient feels a drop or change in the velocity or force of the beat. This is example of sinus bradycardia. First channel, second channel is atrial premature beat, third channel nodal premature beat, fourth channel sinus tachycardia, and the last channel, the P wave, is inverted and near the QRS. This is a nodal or junctional rhythm. Now we come to supraventricular tachyarrhythmia. It can be paroxysmal or persistent or chronic. What is the mechanism of supraventricular tachycardia? The impulse usually passes in the AV node in all the fibers in the same time. Sometimes it passes in one direction and is blocked in the other direction. and it happens that the fibers that block antegrade is not blocking retrograde, so the impulse returns in the blocked pathway and circus movement happens. The management of supraventricular tachycardia is by vagal maneuvers as carotid sinus massage or performance of Valsalva maneuver. If this is not successful, the first line therapy is adenosine intravenous ampoule 6 milligram. If not successful, we can give another 2 ampoules. If not successful, we can give calcium channel blocker verapamil isoptine. The ampoule is 5 milligram. We can give digoxin or beta blockers. If this is not successful, we can give amiodarone, cordarone. Some patients are born with accessory pathway. The accessory pathway transmits the impulse from the SA node directly to the myocardium without passing in the AV node. What is the problem of this? The impulse can pass in the accessory pathway, return in the normal pathway, and then recurs again and causes re-entry and tachyarrhythmia. Or it can pass in the normal pathway and returns in the accessory pathway. This is called Wolff-Parkison-White syndrome, characterized by 3 features. The QRS shows delta wave ascending limb is curving, and the P wave is very near to the QRS, short PR, and the QRS duration is wide. Short PR, delta wave, wide QRS. The treatment of accessory pathway tachyarrhythmia is by flecainide, propafenone, amiodarone, or disopyramide. By digoxin and verapamil are contraindicated. Catheter ablation is the treatment of choice. Now we come to atrial fibrillation. This is a very common arrhythmia. In age above 70, it can occur in 10% of people. It is divided into paroxysmal, persistent, and permanent, chronic. If it is less than 2 days or subsides by itself is called paroxysmal. If it is more than 7 days or does not subside is called persistent. More than 1 year is called chronic. And if it we decide the doctors decides that it cannot be returned to sinus rhythm and the satisfied to give the patient antiarrhythmic drugs for rate control, and the patient is called in chronic or permanent atrial fibrillation. Example of atrial fibrillation: the RR intervals are completely irregular. No RR interval is equal to the other, and the P wave is not present, and instead of it there is F waves. Causes of atrial fibrillation: either structural heart disease or no apparent structural heart disease or minimal structural heart disease. The organic causes: rheumatic mitral valve disease, ischemic heart disease, hypertension, cardiomyopathy, dilated or hypertrophic cardiomyopathy. 1/3 of cases of atrial septal defect, 1/3 of cases of constrictive pericarditis and myocarditis. Without structural heart disease as alcohol, thyrotoxicosis, obesity, smoking, pericarditis, pulmonary embolism, sick sinus syndrome. There was a term previously called lone atrial fibrillation. This term was cancelled, removed, because no atrial fibrillation without cause. If you search thoroughly, you will find a cause, even genetic. Another example of atrial fibrillation: RR intervals are completely irregular and P wave is replaced by F waves. This is a very serious situation. Atrial fibrillation in a patient with accessory pathway. The, the impulse passes from the atrium to the ventricle without passing in the AV node, without any block. The ventricular rate is very high. It can be 250. 250 ventricular rate can cause ventricular fibrillation as in this. So any patient with accessory pathway and atrial fibrillation, ablation must be done very soon. Complications of atrial fibrillation are thromboembolic complications and heart failure and other complications. Atrial thrombi due to stagnation of blood in the fibrillating atria. The formed thrombi may embolize in the systemic or pulmonary circulation, from the left atrium to systemic circulation, from right atrium to pulmonary circulation. Thrombi in left atrial appendage may embolize to brain, causing stroke or transient cerebral ischemic attacks, may embolize to retinal artery, causing sudden blindness in one eye, embolize to other systems. The right atrial thrombi may embolize to the lung, causing pulmonary embolism. Heart failure due to loss of atrial contribution to contractility and the rapid irregular heart rate causes also myocardial affection and heart failure. Other complications of atrial fibrillation, tachycardia-induced cardiomyopathy, and the complications of treatment as bleeding from warfarin and the cost of therapy. Every patient is liable to thromboembolic complications. There are risk factors, major risk factors: previous stroke or transient cerebral ischemic attack or age above 75. Other risk factors: presence of heart failure or left ventricular dysfunction, hypertension, diabetes, age between 65 and 74, female sex, and vascular disease as peripheral or carotid vascular disease. We give a score to every point of this. Previous stroke and age above 75, 2 points. The other are 1 point. If the patient is having 2 or more points of this risk score, he is liable to thromboembolism and indicated for anticoagulants. If the risk is just 1 point only, in some patients we advise anticoagulants also. If there are no risk factors at all, the possibility of thromboembolism is low and we may not give anticoagulants. Again, these are the score is called Shad-Fusk score. Heart failure 1 point, hypertension 1 point, age above 75 2 points, diabetes, stroke 2 points. The maximum is 9 if the patient is having all risk factors. Every patient with atrial fibrillation will receive anticoagulants. Some are liable for bleeding. If he is having hypertension, abnormal renal or liver function, previous stroke, previous bleeding, labile INR, sometimes the INR below 2, sometimes above 4, this is risk factor for bleeding. Elderly above 65, taking drugs as anti-rheumatic drugs or taking alcohol, this is also risk for bleeding. Also, the maximum score is 9 points. So this is called has bleeding risk score. But what is the importance of this? If I know that the patient is having very high risk, I try to be modest in giving anticoagulants, not the full dose. Treatment of atrial fibrillation, pharmacologic or by ablation. The drugs, if the patient is unstable with shock or heart failure or during myocardial infarction, there is no time to wait for drugs, we do cardioversion. And even if it is urgent, we will give anti-arrhythmic drug amiodarone before the cardioversion. For recurrent or persistent atrial fibrillation, minimal or no symptoms, we give anticoagulation and rate control. For disabling symptoms, we give anticoagulation and rate control, antiarrhythmic drugs, or electric cardioversion if unstable. Permanent atrial fibrillation, we give anticoagulation and rate control. Ablation if atrial fibrillation is symptomatic, not responding to drugs. These are the drugs used for rhythm control: amiodarone, flecainide, sotalol, propafenone, and ritmonorm. And these are the drugs used for rate control: digoxin, beta blockers, verapamil. Anticoagulation with atrial fibrillation, the indications are, in fact, any patient with atrial fibrillation must receive anticoagulants as long as the score is 1 or more. Rheumatic mitral valve disease or with recurrent or chronic atrial fibrillation, dilated cardiomyopathy with recurrent, persistent, or chronic atrial fibrillation, prosthetic valves, of course, will receive anticoagulation. Anticoagulations more than 3 weeks. We give anticoagulation for 3 weeks before doing electric cardioversion or pharmacologic cardioversion, and to be sure that the patient is receiving the anticoagulants really. If the atrial fibrillation is below 48 hours, we can give heparin and electric cardioversion or pharmacologic cardioversion. These are the new oral anticoagulants: rivaroxaban, Xarelto, apixaban, Eliquis, dabigatran, Pradaxa. The price is about 1,000 for the original or 400 pounds for the generic. If the patient is unable to pay any of these, he can take the warfarin or Marivan. Atrial flutter. We finished about atrial fibrillation. You must revise it again and remember the treatment and the complications. Atrial flutter is the presence of ectopic focus in the atrium with re-entry around rate of 300 to 360. The AV node cannot transmit all this, so it transmits one, and there is a refractory period till the second impulse. So the ventricle receives half the atrial rate. So the ventricular rate is about 150. This is 2 to 1 atrial flutter, the 2 P waves and then QRS. This patient with atrial flutter received drugs. The block was more, so it is 4 to 1, 4 P waves and 1 QRS. The management of atrial flutter is by ablation because it is resistant to drugs, and it must be given anticoagulants, also treated as atrial fibrillation with anticoagulants. Ablation, we have center in Alexandria, very advanced center in Egypt. We are proud of it. We can do ablation for this arrhythmia: atrial flutter and fibrillation, AV nodal reentry, accessory pathway, ventricular tachycardia, and ventricular premature beats. There is congenital disease called long QT interval. This can lead to sudden death. The normal QT in men is below 0.43 and in women below 0.43 second. Example of very long QT, you see from the beginning of QRS to the end of T is long QT. And from the beginning of QRS to the end of the T is long QT. Is called Romano-Ward syndrome. Another example, very long QT from the beginning of QRS to the end of T, very long. This can lead to sudden death. Now we come to another type of arrhythmia, ventricular tachycardia. Wide QRS, bizarre shape. The R wave is opposite to the T wave, and there are concordance in the chest leads from V1 to V6, mostly in one direction, up or down, and there are AV dissociation. Another example of ventricular tachycardia. Another example of ventricular tachycardia. Very wide QRS. Very wide QRS. This is transient, non-sustained ventricular tachycardia. If it is below half minute, 30 seconds, is called non-sustained ventricular tachycardia. The patient is having other pathologies as ischemia, anterior ischemia. In patients who have long QT, it can lead to type of ventricular tachycardia is called torsade 1, the polymorphic ventricular tachycardia. Some impulses directed up, some impulses directed down, and see here very long QT. So this is example of long QT that led to ventricular tachycardia is called torsade 1. The problem of arrhythmia is that can it lead to ventricular fibrillation. The mode of death in most of the patients is ventricular fibrillation, and it is called primary or secondary. If it is after myocardial infarction, for example, it's called secondary. If it is the patient was having nearly normal or minimal abnormality in the heart and then gets a premature beat that leads to ventricular fibrillation is called primary. It is a condition in which many electrical signals are sent from the ventricles at a very fast and erratic rate. The only life-saving measure to do for ventricular fibrillation is defibrillation, electric defibrillation. If you don't have defibrillator, the only hope you can give amiodarone intravenous. It may succeed in 17% of cases, and even before defibrillation, give also amiodarone intravenous. Example of ventricular fibrillation. We finished these types of arrhythmias. We come to heart block. Is divided into type 1, type 2, type 3. Type 1, prolonged PR. Type 2, progressive prolongation of PR till there is failure of conduction or sudden failure of conduction. This is example of progressive prolongation of PR interval till there is failure of conduction. It's called Winkelbach phenomena. And this is example of complete heart block. There is no relation between the P wave and the QRS, divorced from each other. Complete heart block. The atrium is following the focus in the SA node, and the ventricle is following focus in the ventricle. This focus in the ventricle from Purkinje fibers is unreliable, undependable, can stop at any time, and the patient can die. The management is pacemaker, and the pacemaker can be with one lead, single chamber, or with two leads, dual chamber. Another example of ventricular complete heart block. There is no relation between the P wave and the QRS. Thank you. Best wishes. I hope it was simple.